All right. Hello, everybody, and thank you for coming to the Norton Infectious Disease Institute Grand Rounds. Today we have with us Lindsay Olmstead, who is the manager for respiratory therapy at Norton Children's Hospital, and she's going to talk to us today about airway clearance, which we thought was a perfect topic in light of respiratory season. So thank you, Lindsay. Take it away.
Thank you. Is my correct screen shared?
Yes, it is.
Okay. So, like she said, I'm Lindsay. I'm the manager for Norton Children's Hospital Respiratory Care. I'll be talking to you today about airway clearance. So we're going to go over normal function, impaired function, different methods of airway clearance, determinants of airway clearance, and some briefly contraindications. So airway clearance therapy is performed by respiratory therapists, and it's intended to aid in secretion mobilization and expectoration. And this helps to reduce complications associated with secretion retention. So the natural or normal airway clearance is a function of the mucociliary escalator and a cough reflex. So this defends the respiratory system by facilitating secretion clearance and preventing airway obstruction. So many factors make it difficult to mobilize and evacuate secretions. The mucociliary escalator can be impaired by aging, tobacco use, environmental exposures, different disorders that we're going to get into, and then neurologic or neurodegenerative conditions decrease the ability to cough effectively, leading to those secretion retentions. There's really two things going on. It's the process of moving everything out and then getting it out. So airway clearance therapy uses a physical or mechanical means to manipulate airflow, to mobilize secretions, and facilitate that cough. So I touched on a little bit, but the normal function of the airway clearance, primary through the mucociliary escalator, it is a structure that has tiny hairs that move together to propel mucus containing particles out. And then you have that cough that has to actually expel those secretions from the airways. I'm going to show you a little video. It really talks about humidity more because humidity does impact the functionality of that mucociliary escalator. But I think it's a good video to show what a normal healthy ciliary look like and what one that's compromised look like. So I'm going to attempt to play that now.
As the clip starts, the right trachea has been exposed to a constant airflow at lower humidity for 15 minutes. Although you can see tiny beating cilia flickering in the background of both clips at this stage, debris in the mucus of the right clip is stationary. Mucus transport is essential to stop. The dark spots moving quickly across the left clip now show debris being cleared by effective mucociliary transport. After only an hour at the lower humidity, the mucus layer at the right is completely dried out.
Okay. So that video just really shows how when it's not working properly, you can see that buildup of that debris and those secretions that could cause issues with airway obstruction. This is just a little picture of what that would look like. So you have your ciliary, you have that mucus layer, which with certain conditions that's thickened and it's harder to move it up, and the particles kind of become, they stay there and you have that airway obstruction. So that's just a little diagram of that to help you visualize that. Then for things that can impair the airway clearance, you have excessive mucus production. So some diseases cause abnormally thick or copious mucus, making it difficult to expel. You have the ciliary dysfunction, which you saw in that video, that significantly reduces the clearance ability. Airway obstruction or inflammation. So that narrows the airways due to inflammation, tumor, structural abnormalities that can impede mucus movement as well. You get into muscle weakness. So neuromuscular conditions can weaken the muscles used for coughing, and that impacts the force needed to clear secretions out. So the conditions can include spinal cord injury, primary neurologic condition, generalized weaknesses, neuromuscular disorders. It's just a wide range of disorders. They each have varying onsets. They have different rates of progression and different patterns of muscle involvement. But they eventually lead to involvement of the respiratory muscles. So if you think about it, the inspiratory muscle weakness decreases the ability to take that big, deep breath in. The expiratory muscle weakness decreases the ability to generate the sufficient pressure to cough effectively. And that's why you have so many issues with the neuromuscular weakness or disorders. Cystic fibrosis patients have that very thick mucus production in the lungs. It causes frequent infections and impaired clearance. COPD patients, they have the chronic bronchitis and emphysema. With the increased mucus production, airway inflammation, which affects clearance. But to note on that, COPD, the airway clearance therapy is not like routinely recommended for COPD patients unless they're symptomatic with the secretion retention. With the severe asthmatics, again, airway inflammation, mucus production, that can impair the clearance. So a lot of those patients, I'm a pediatric RT here at the hospital, you know, we have issues with them coming off of oxygen, then we'll start them on the airway clearance therapies. You have post-surgical complications and anesthesia. So go to the next slide for those. So impaired function with anesthesia. This is really concerning in patients with already pre-existing respiratory issues. With anesthesia, you have muscle relaxation, and that includes muscles that support the airway, that can cause tongue to fall back, obstructing the throat. You have the loss of a cough reflex, making it difficult to clear the mucus of the airways. You have reduced lung volumes, so it can decrease that functional residual capacity, which is, you know, that amount of air remaining in the lungs after normal breath, which can kind of lead to some atelectasis. You have, with certain anesthesias, you can have an increase in mucus production. In different anesthesia medications can have varying effects on airway muscle tone and respiratory function. And with positioning of these patients, supine positioning can, for long periods of time, or just in general, can exacerbate airway obstruction by putting pressure on that airway. So that's where you have some of that impaired function with anesthesia. And then surgery, with surgery, post-surgery can significantly impair natural airway clearance due to factors like pain. You know, you can't take that big deep breath in, you can't have that effective cough. Again, you're, you know, under anesthesia, you get that mucus production, muscle weakness from surgery, changes in lung positioning. This all leads up to that mucus buildup. And then that's why it's so important post-surgically, we encourage patients to perform deep breathing exercises and cough to clear those secretions effectively. There is more evidence that shows that early mobility is better or the best practice than airway clearance therapy in reducing instances of post-operative pulmonary complications and decreased hospital stay. So just getting that patient up and moving is the best practice for those patients. So different methods of airway clearance. I'm just going to go over some of the things we do here. And we'll go through them a little bit more in detail with the next slides. But when considering which method of airway clearance you're going to use, you always have to consider like the degree of the patient effort. A lot of things in the respiratory world are patient effort and the ability of the caregiver to instruct that patient or help them with what they're doing. So if they have an effective cough, then really airway clearance may not be your first concern because they're moving their secretions on their own. They're getting that out. What can their caregiver effectively help them with? What can the cost to them? A lot of these things are very expensive, like to go home with. It's expensive in the hospital setting. Can they do it on their own? Most of our pediatric patients can't do these things on their own. It takes a lot of coaching to do these different maneuvers and different machines with them. So when we're looking at the different methods, like who needs these? Well, it's the patient with the reduced cough reflex and those retained secretions. So those are the people you're going to want to order these things on. Sorry, I got to get over to my screen. So number one I want to talk about is postural drainage. This little diagram here has been in respiratory schools across the world for like probably the last 40 years. So it breaks down where the consolidation is. So if I have a lower lobe posterior segment that I want to hit, then I'm going to put my patient in position 7. And then I'm going to do some manual percussion with them, or they could even be on a vest. And we'll go over all those different things here in a second. Some barriers to this would be the caregiver's ability to get the patient in this position. The patient's ability to actually get in this position. It may be uncomfortable for them. They may have lines. They may have something else going on where they can't get in this position. So you can do the therapy, but if you're not adding the postural drainage, you're not using gravity to move things up where it can help it come out, the secretions come out. You may not be giving them the best therapy if you can't utilize this postural drainage. So with postural drainage, these are some manual ways we can do the airway clearance. So we have a manual percussor with the little blue cup, and you just kind of hit the patient in the area you want. You can use your hands. Pneumatic percussor, we use a lot of these here, and it just is good to hit those certain areas. So if you have something showing on an x-ray, this is where we're seeing this consolidation. This is where I want you to hit. That's great. We can get them in that drainage position and then percuss them in that area. The bottom one, the little baby, that's a neocuster. I'm not sure if you guys can see it, but it's like a little toothbrush with a little vibrating head. These work great in the NICU. So all different sizes and ways you can do this. The blue cup we'll send home with our parents so they can do it at home for a couple of days. And we just try to instruct them best we can to, stay away from, the bony structures and things like that. The next, we have active cycles of breathing. Again, the degree of the patient effort is going to determine if this is effective. If they have that effective cough, the caregiver's ability to teach this, if you don't teach this or use this a lot, then, you're not really going to be able to effectively walk somebody through how to do this. The age of your patient, we don't do a lot of this at the PEDS hospital because it's very hard to teach these kids how to do this. This uses forced expiratory technique. and collateral ventilation, which we're going to get to next. So it kind of breaks it down for you. So you're going to do your diaphragmatic breathing, try to get to that maximal inspiration, a little hold, do that sniff to activate that collateral ventilation. And then you're going to do your forced expiratory, like a huff, to force that air out to get the, so what you're doing is you're getting that air back behind that obstruction, back into those collapsed alveoli, and then reinflating them and moving those secretions up. And you'll do that, you'll teach them to do that until you're non-productive for 2 consecutive cycles. Again, this is probably more in the adult world than the pediatric world. This is just a little diagram of collateral ventilation. Collateral ventilation is super important when it comes to airway clearance. So just walk you through this. You have this obstruction here. This little black dot is this obstruction. You still have some gas exchange going on, but then once no gas exchange occurs, then you have that collapsed air sac there, atelectasis develops. You're not using any collateral ventilation, and that's what you have. If you activate that collateral ventilation, which is right here, you're activating that, you're getting that air back behind that obstruction. You're participating in gas exchange again. You can use that forceful cough to kind of push that obstruction out. I really like, talking about this, understanding kind of the physiology behind this, because I think it's very helpful to understand, why we're doing that deep breath, why we're having that breath hold, why we're forcefully exhaling. This is a good kind of diagram that talks about that. Different device, like I said, we're going down different devices that we use. This is a pickle, acapella. The adult world uses the Arabica. It's just simple to use. It's similar to like a bubble, like physically blowing bubbles, pinwheel, but with resistance. So you're taking a breath, big deep breath, you're forcing air out against resistance. There's a flutter valve in here. And then that kind of helps shake up the secretions that are in the airway. And then once you're done, you should do that cough. We do this about 3 cycles of 10 breaths. I like this because with the older kids, you can say, do it in between your movies, every 4 hours, whatever, and they can do it on their own and just really get the benefits of it. But it does take initial coaching, making sure they're doing it right. Cough assist. This is a cough assist machine. I'm sorry for the blurry picture. So when we talked about, the normal function of airway clearance, you have your mucociliary escalator, and then you have that forceful cough at the end. So this is really for patients who don't have that forceful cough at the end. So this is for like your muscle weakness, neurologic patients. There is a manometer on the side here that tells you what pressure you're getting. This is like patient dependent. You can use a face mask. You can hook it directly up to a trach, which I like to do because it works very well with those patients. But if they're not getting that tight seal and you're not getting that patient effort, then it's not the best. You're just really kind of wasting your time because they're not getting what they need to have an effective cough at the end. The cough assist machine can be used after any of the other devices that I'm talking about. But any of the other devices really shouldn't be used together because they're all doing the same thing. So again, just want to say the cough assist it's beneficial to use it after the other airway clearance therapies to help facilitate that cough once you've broken things up and moved things along, if that makes sense. Again, it's expensive and requires trained staff to use it. We do have people that do it at home so the family can be trained. And I think it's great that the family does do it at home because it can really keep them out of the hospital. Two other modes here. We have our vest machine, which is this purple vest here. This can be used in adult world, pediatric world. It goes super small to little babies. So the vest fills up with air, it shakes, it contracts, and as that air is filling up, inflating and deflating rapidly, it's breaking the mucus up from the side of the airways and moving it up. Again, once you've moved it up, you still have to have that cough. So if you have a patient that is using this and you can hear it, maybe they're struggling to cough, it's okay to use that cough assist when they're done with this, to do that whole process of that airway clearance. The Valera here is kind of the same, but it's like more, I call it internal. So you have a manometer on the side here. You set a pressure. You can give it with a mouthpiece, a mask. You can hook it to a ventilator on patients 2 and above, or you can hook it directly to a trach, which again, I love it. With it, you do have to make sure you have that tight seal. You'll get a consistent pressure for about 2.5 minutes, and then you'll go to that auscultating pressure for about 2.5 minutes, and you'll drop back down, and you'll repeat that cycle. And that just really helps break things up, move things up. But again, you still have to have that cough. So you can use a cough assist following this device too. If your patient is not coughing, if your patient has that effective cough, they don't need it. But this is a really good device to use. Barriers, again, expensive. Both of these things could be very time consuming. If you have a cystic fibrosis patient, they could use this up to 30 minutes, 3 times a day, 4 times a day. So very time consuming for them. So then it gets into like patient dependency, like, do they really want to do their therapy? They do have a portable device, which is really cool. Somebody with CF created it because I think he flew planes and he wanted to be able to do his treatments while he flew. So that's really cool that those older, more active kids, I'm sorry, I keep referring to kids because that's my world, are able to take this with them and still effectively do their therapies. Just making sure. So I did throw on instead of a spirometer, it facilitates lung expansion by taking deep breaths, and it can induce a cough. So kind of in the family, but not considered, airway clearance technique, but you are facilitating that lung expansion. When you talk about that lung expansion, that deep breaths, that breath hold, is when you use one of these, you're putting the mouthpiece in, you're setting that target, you get it to as high as you can go comfortably. And then you do that breath hold. And so you're activating that collateral ventilation, you're getting back behind those obstructions, you're getting air to those collapsed alveoli, and you're coughing. So that's kind of how this works. So that's how this works with that lung expansion. So it helps prevent lung infections by expanding your lungs, strengthening your lungs, keeping your lungs inflated, clearing mucus. If you may have low oxygen levels after surgery or serious illness, and an IS can help you achieve normal oxygen levels. So it's really improving lung ventilation. According to American Academy of Respiratory Care, it's not really recommended for routine prophylactic use in postoperative patients. Early mobility and ambulation is still one of the top recommendations for that to promote airway clearance. So those are the methods of airway clearance that we use the most here. So determinants of airway clearance. So when you're deciding, my patient needs this, what are some things you want to look at? The rationale. Does the patient actually have difficulty clearing airway secretions? Are they retaining secretions that's affecting gas exchange or lung mechanics? So really, you should be paying attention to the difficulty the patient is having while attempting to mobilize or expectorate airway secretions. That's what like our main focus is. If they have an effective cough, that's good. That's what we want. Are they getting stuff up? That's good. That's what we want. Is it a little thick? Okay, that's fine, but they're still getting it up. They're still able to mobilize it. Adverse effects. So this is where you really want to use your RT. Again, I refer back to the pediatric world because we have so many different age groups, so many different size patients. So what therapy is likely to provide the greatest benefit with the least harm? My Valera probably is going to give the best benefit, but if the patient isn't doing it appropriately, it's probably doing more harm than it is good. And I could switch to something that is going to do more of a benefit for them because they're using it appropriately and they're actually getting the therapy. So that's where you'd really talk to your RT and say, what's going on with this patient? What's their mental state? What's their, do they have any facial things that, they can't use the mask? Do they follow directions? Things like that. Do they even want to do it? If they're not wanting to give effort, then we need to go something that's, that's least patient driven. So that's just really something to think about with that. Cost. What is the cost of the therapy in terms of the device cost, clinician time to apply or supervise therapy, and home use as well. Like they can take a lot of these things home. Insurance drives a lot of things, like when they can get a new machine, how many different machines they can get. And then we get into the mindset, it doesn't hurt to do it, but also not really helpful. That drives up therapy costs to patients, and you got to factor in like clinician time as well. And then patient preference. Again, you get that patient who needs it, but doesn't really want to do it. So what's the best one to get them the best benefit? Okay, those are just some things to think about when you're determining airway clearance. Contraindications, bleeding disorders, discomfort due to physical positions, manipulation, rib fractures, lines. There's like, if you think back to the vest, if they have lines, we can't put a vest on, but maybe we can attack just one side manually or with a pneumatic percussor. You kind of want to think about what's going on with your patient. Not really a ton of complications with airway clearance therapy, but it's related to position-related hypoxia and aspiration of freed secretions and other lung regions. Also, you want to consider food. Like, I'm not doing it 30 minutes. If they ate 5 minutes before I walked in the room, it's not the best time to do it, because with airway clearance, you also want to think about suctioning. If your patient, you're moving the stuff up, you're going to go in there and suction, especially with the babies. We may do like a deep suction, and that could cause, gagging or coughing that could bring up that food or that bottle. And then we worry about aspiration. So those are just some of the complications with that. Here are my references. And I think that I am done.
Thank you very much. Anybody have any questions for Lindsay? I think this is always very interesting, the different, options that are available and the intention behind each one of them. So very helpful for me and very pertinent, particularly during this time of year when we have a lot of patients that come to the hospital, with respiratory illnesses or compromise. So anyone have any questions? If not, thank you very much. This will be posted to our YouTube channel. And just a reminder, we will not have any more Grand Rounds for 2024, but we will be back at it in January of 2025. So thank you, and I hope everyone has a fantastic day.